Good morning, everyone, and welcome to our webinar. This is Courtney, the Marketing Coordinator here at Aetna. Today's webinar will be recorded and later posted on our website. This does mean that all attendees will be automatically muted so that we can get a quality recording today. If you have any questions, feel free to type them into the chat box. We'll try to answer them throughout the presentation and at the end with our Q&A session. But if we're unable to get to all the questions, we'll have a member of our marketing team reach out to you individually to make sure we can get those answered. We do have webinars every Wednesday morning, so keep an eye on your email or on our website to sign up for the next one. With that, I will go ahead and hand it on over to Derek so that we can get started. Go ahead and take it away, Derek.
Thank you, Courtney. Welcome, everybody. I hope you're having a great morning. Today is going to be a really great webinar. So we're going over Aetna's recovery care and home care with a little bit of a twist. It's going to be a little bit more on selling and some different aspects to that. To kind of really jump into that, we have Ronnie Lipinski, who is a national trainer in ancillary senior supplement products. He's been doing this for over 20 years, so a lot of great experience that's going to come with some of the advice you're going to get here. With that, I'm going to go ahead and say good morning, Ronnie, and kind of let you take the show.
Hey, Ronnie. Just a heads up, it looks like your presentation had disappeared real quick. Oh, there we go.
There we go.
Perfect. Thank you.
You're welcome. Are we ready to go?
We are ready for you, Ronnie.
All right, thanks. I don't know what happened. My everything shut down. So that was crazy. Good morning, everybody. I apologize for that. My name is Ron Lipinski. Love what I do. Each and every day I wake up for the past 23 years, going and meeting people and helping people with their insurance needs and concerns and questions and their stack of confusion that they get during AEP and throughout the year. So I just love waking up every morning and helping people with insurance. Today we'll be going over some of the Aetna products that I love to place in houses. I'm a long-term care guy, Medicare Advantage, Medicare Supplement, and everything in between. And I love Aetna for a couple different reasons. Aetna has been around for a long time, since 1853, 170 years now. They've been promoting and doing these lines of products for over 30 years. So they're not a Johnny come lately to the short-term care plans. They've been there, done that for a long time. Not only do they have a household name along with CVS, but I trust my clients to the people that are behind the Aetna name, the policy service people, the claims, underwriting, and that's what I'm entrusting my book of business to and my renewal. I love the upfront money that you get on placing a policy in a house, but I live and breathe for my book of business to renew. And I have over a 90% retention rate with my Aetna products. And one of the reasons that I have that retention rate is because of the Aetna name, along with CVS, and because of the people that are behind the Aetna name. So I always love to start out and give Aetna a few props, because I'm licensed with all the major ones: Humana, United Healthcare. I have every, dental, vision, and hearing, PDD plan. I have all different carriers available to me to place in front of my clients. But when I'm talking about these specific products that we're going to talk about today, I keep finding myself going back to them, and it's because I trust those products. I don't get phone calls for rate increases, and I don't get any phone calls because they couldn't get answered when they contacted the Aetna people. So I love to share that with you. And what I'm going to share with you today is a high level of what I do if I'm doing a telesales call or a Zoom call or a FaceTime or belly to belly in a house, boots on the ground. I like to educate people on what's going on with Medicare. So I do a high level educational with them. And what that does for me, and what I've noticed over my 23 years of doing this, is it sets me apart from a lot of other agents that aren't going into a little bit of the history with Medicare and what's going on with it since it started in 1965. to 2024. And that separates me from the other agents that are calling them or sitting in front of me, because I'm doing something a little bit different and throwing a little bit more information out there that they don't normally get, which opens up their eyes, and I see them leaning into the conversation instead of sitting back with their arms crossed or looking at their watch or giving me all them other signs that us agents don't like to see. So I want to inform them at high level on what Medicare is doing, and with me doing that, that helps them understand what the need is. These next 3 slides are slides that I look at every single morning that I wake up, because it gets me going better than any coffee. Medicare has 61 million beneficiaries as of now, which is 18% of the population. But this next slide is the one that gets me going. This is my Red Bull right here. By 2030, there's 79 million people expected to be enrolled in Medicare. That is a ton of new business for myself and for all you guys out there. Man, there's not enough of us to get to everybody. So what business can you be in that's going to keep growing and growing and growing, but the business that we're in? So that really gets me excited and gets me pumped up, even on the cold days like it is today here in Indianapolis. It's 28 degrees and snowing, but I'm loving going out knocking on doors, because I know I have that opportunity to make a sale because of someone missing part of their coverage unknowingly. And then when I go in there and explain to them, they know what the gap is and what's going on. So I like to focus on life expectancy, because that's the whole big dilemma with Medicare. Is Medicare started out, as you can see, us guys live to be about 66 years of age, and you girls just under 74. But with better technology, better medicines, the food we eat, taking better care of ourselves, we have increased longevity to a rate that Medicare never put any provisions into the system to combat. Now they're having to deal with people existing on Medicare a whole lot longer than they ever anticipated, much longer. So that's one of the big problems that Medicare is facing. And what they're doing is they're slicing and dicing and doing different things to the Part A of Medicare, because that's the part you pay into when you're working. And when you retire, you don't pay into. So as you can see, when Medicare's people paying into it to people receiving it has changed over the years, which is now under 3 to 1 recipient, and it's going to continue to fall. So there's not enough money going into the system that there once was, and that's the problem that they're facing. And the biggest things that they're having hemorrhaging of money is readmissions and inpatient patients. So this costs them a ton of money. So they're really scouring and really scrutinizing any readmission patient and inpatient. And if they determine that it's an incorrect categorization, they have been penalizing the hospitals and fining them. And that's a big problem with the hospitals, which turns into problems for the patients. So they're really looking at these records and making sure that they are supposed to be readmitted for that condition, or there should be an inpatient. This is a video that I show on my Zooms and when I'm in person, and this is a short clip out of Indiana on readmissions.
Patients are being readmitted to hospitals. Officials say it's costing you billions of dollars a year. Now, several Indiana hospitals are looking at fines because of it. 66 Indiana hospitals will be docked $12 million total next year. That's in Medicare payments. Federal officials say too many patients came back for care within a month of being discharged. Only 17 hospitals in the state will not be penalized. Officials say readmissions are often unnecessary. They say it's usually because of treatment that should have been prescribed during the first visit.
So Indiana isn't the biggest state in our 50 states, but it's still a pretty sizable state. And I don't know if you caught that, but only 17 hospitals out of the whole entire state of Indiana wasn't fined. So that just shows you how many hospitals, not just in Indiana, but around the country of the United States, that are being fined. So as patients, we see those hospitals as a place to get better and to get fixed whatever's going on with us, but it's also a place of business. So when they start getting fines and they start getting their payments taken away from them because of what they deem an inappropriate readmission, that's a big deal for the hospitals, and they don't like that. So Medicare has become a big auditor of these hospitals, and they have what they call RACs in every single hospital across every single town and every single city in the United States of America. And these RACs are paid compensation to scrutinize these medical records and to find any smallest correct error that they can find to take that hospital reimbursement back and find the hospitals. So it's really becoming a big epidemic and a big problem across the country. And there's a lot of penalties being handed out to these hospitals. So that's not good for the hospitals, and they need to try to avoid these penalties. And they've tried to get on the same page with Medicare, but they can't seem to do it. So they have found a way around getting penalized. And a lot of you might be familiar with this term, observation status. And that's what they're doing to combat the penalties that Medicare is imposing on them by categorizing the patients that should be an inpatient now under observation, which technically makes them an outpatient, where that's a loophole for the hospital because Medicare can only audit, the RACs can only audit inpatient patients. So that's how they're getting around it. So a lot of people that I see, they are familiar with the observation term, but they really don't understand how that affects them clearly. So I go in and explain to them what observation is and how that affects them and how it keeps increasing year after year, and there's no stopping, and no short-term fix for it. So I have them grab their Medicare and You book that they all get each and every year, the 2024 book out this year, and I have them turn to page 28. And this is exactly what's on page 28. And as you can see at the top, am I an inpatient or outpatient? Question mark. I'm like, why do you think there's a question mark on there? If you stay 24 hours and you've been there 48 hours or 72 hours, wouldn't you think that you're an inpatient? And they all nod their head, yes. I said, but as you can see here, it doesn't necessarily say that you're going to be an inpatient, but it tells you whether you're an inpatient or outpatient affects how much you pay for hospital services, and if you qualify for the Part H skilled nursing facility. And then I read the 2 bullet points to them. You're an inpatient when the hospital formally admits you with the doctor's order. That's how you become an inpatient. If they don't, then you are considered under observation. Even if you're getting these x-rays and all these different things, it says, even if you spend a night in the hospital, that doesn't mean that you're an inpatient. That's why in bold black lettering, it says each day you have to stay, someone on your behalf or yourself should ask somebody in the hospital if you're an inpatient or outpatient. Because on Wednesday, you can be an inpatient. Come Thursday, you can be under observation. And then come Friday, you can be under observation. That's the cat and mouse game that the hospitals and Medicare are dealing with. So I bring their eyes down to the 4th paragraph where it says skilled nursing facility, and it says medically necessary services and supplies in a skilled nursing facility. Medicare only covers these services after a 3-day minimum medically necessary, and there it is right there, inpatient hospital stay. So if they don't satisfy that requirement, when they go from the hospital into a rehabilitation center or a nursing home, they're not going to qualify for those 20 days that Medicare generally pays. That's a problem. That's a big, big problem. Even if they have an MA plan, it does say you need to check to make sure that that's going to be approved, even if you're under observation. That's a big deal too, because typically the Medicare Advantage would always approve of it. But I've already seen this year, 2024, and we're only into it 2 months. I've had 8 different people, clients of mine, that have been denied aftercare because of observation. Big, big problem. So once I go off that page 28, I show this short video to them on a testimony, an example of a lady that had Blue Cross Blue Shield. She broke her leg, and this is her story.
Sure.
79-year-old MJ Bricu is doing physical therapy after a bad spill in September. She spent 3 days in a hospital. She got the same care as an inpatient, but she wasn't classified as one. Instead, her chart said she was only under observation.
I mean, it's illogical. I had a broken leg. It just didn't make sense at all. What were they going to observe?
And here's what she didn't understand at first. That label, under observation, technically made her an outpatient. And that means Medicare won't pay for her rehabilitation in a nursing facility, which costs $28,000.
The whole thing is so outrageous, and it's not right.
It's a huge problem. There are over 1 million, almost 2 million people every year who are stuck in this observation state as Alice in Wonderland world.
To the patient, to our viewers, frankly, it seems like the hospital shares at least part of the blame for this.
Sure, they're in the hospital. They're going to think all of this is a hospital decision. Much of this is out of our hands.
Rich Umdenstock, who represents most of the hospitals in this country, says they're being squeezed by Medicare. Inpatients cost more, so Medicare aggressively audits the classifications given to patients.
If you make the wrong decision, if you admit a patient to inpatient status, and then they determine after the fact, sometimes years later, with additional information the physician didn't have, they will take that payment back. Unfortunately, the patient does get in the middle of this.
We wanted to talk to Medicare, but they denied our request for an interview, citing pending litigation on this very issue. The hospital that treated Mary Jane wouldn't talk to us either, but gave us a statement saying it is obligated to follow Medicare rules when assigning patients to their appropriate level of care. MJ finds the whole thing unfair. She and her husband, who's had Parkinson's for 20 years, just moved in with their son in Dallas to save money.
I've worked my whole life, and I'm just appalled.
Now any money they can save will go to her rehab.
So when I quit playing that video, their jaws are on the kitchen table, or I can hear them on the other line. They're really in tune and really a gasp of how that is going to affect them. And I let them know $28,300 MJ wasn't expected to pay because she had an accident, sickness, or surgery. And her accident, which caused her to break a leg, caused her to hemorrhage $28,000 that she didn't have planned for that year. So with me going over at a high level what's going on with Medicare, having them go get their Medicare book or their Medicare Advantage explanation of benefits booklet, and guiding them to the key pages in those booklets, and then playing those videos and explaining to them how that affects them and what that gap is with their Aetna, with their Blue Cross Blue Shield because of these changes, and what their cost share is going to be if they have an accident, sickness, or surgery, and that 70% of the people that turn age 65 are going to experience some type of rehabilitation and some type of long-term care service. That really opens up their eyes. And like I said, I can see them leaning into the conversation even more, because at this point in the conversation now, even though they're not saying it yet, they want to know how they can fix it. Or sometimes they come out and say, well, what can we do about this? Or am I able to fix this? Or do I just have to deal with it? And them are all the things that we want to hear when we're in a house doing their Medicare review or going over their insurance portfolio. When we see a gap, that's what we want. We want to hear, because now we know we got the need across. So these are some of the things that I utilize on my telesales calls, my Zoom calls, and my belly-to-belly appointments to get that point across. So when I usually stop that video a little bit early, and I keep this on the screen to let them know this is what you're potentially going to be out of pocket if you have that same accident that MJ did and you were under observation. So as a long-term care guy, I like statistics and numbers, and they've been changing here over the years that I've been doing this. And as you can see now, a lot of the care is done within 2 years of someone going into a facility. For guys, average is under a year, and you girls just under a year and a half. So the short-term care plans have really come to the forefront of our industry, where before they took a back seat to long-term care. That isn't the case anymore because of the observation and so many people living a lot longer. a lot of the people, about 52% of the people in rehabilitation centers or nursing homes are in there for rehab. So these short-term care plans have really come in at the perfect time to fix the situation that our clients are going to be faced with at some point in their life. So one of my go-to policies is Aetna's Recovery Care. I love this policy. I sell it weekly. It's just a great policy for our clients, and it's a great policy for us agents, especially if you have a long-term care background. It has a lot of the same benefits that long-term care has. It's just for a shorter amount of time. As you can see, the issue ages are from age 50 to 89, no gender-based rates, and my favorite one is no height and weight, because I used to run into where I was knocked out because the weight chart said that they were obese, even though they get up out of bed, they're doing yard work, but because of the height and weight chart, they're short and they're a little bit more stubby, they're considered obese. Don't have that problem with this particular policy. No underwriting or phone interview, no medical records to issue. And we'll get into that later on in the conversation. That last box on that left-hand corner pays in addition to any other insurance. I love that fact, because just say they do qualify for the 20 days that Medicare pays and they have this policy, it'll pay them directly. Even though Medicare paid for their first 20 days, if they have a $200 a day benefit, they'll get paid $200 a day for however many days are in there. A check sent directly to them that they can utilize in whatever way they want. But I love that this pays in addition to any other insurance. No hospital stays required, any licensed nursing facility or assisted living or home health care agency. And the very last box is really near and dear to me, because renewal premiums do not increase because of age or health. That is one of the reasons why my book of business stays where it does, because they're not getting a premium increase. They're not getting an increase every 5 years or 4 years or whatever the block is. Once they're locked in, that rate stays the same for the life of the policy, unless they change everybody across the country that has that same policy. And that's what I go back to my initial point when I first started my presentation is Aetna's never had a rate increase. They've been doing it for over 3 decades. They know what they're doing. That's why I utilize them for these particular policies, because I don't have to worry about getting a phone call about any rate increases. So as you can see, the benefits are a la carte. If you can choose from a $10 benefit all the way up to $400. So if you gave them the $400 benefit for a month, they would have a $12,000 monthly benefit. For if you gave them up to the 360 days, they would have $144,000. Very, very good benefit. If you chose to give them $200 a day, $6,000 a month, $72,000 a year, still a very good benefit. On the days covered, 90, 180, 270, 360, a lot of houses that I run into, some of them have long-term care. Well, what were a lot of the long-term care agents trained to do? Give them an elimination period. My manager wanted me to give an elimination period when I first started selling long-term care, because they said Medicare and their Medicare supplement, their Aetna, is going to pay for the first 100 days. So a lot of those plans out there have a 90 or 100-day elimination. Weekly, I run into someone that has a Genworth or John Hancock that has, or a Banker's Life that has a 90-day elimination. What do? I give them a 90-day benefit to cover that elimination period, and the policies will work together where they'll have first day coverage, where before they were going to be out that first 90 days because it doesn't pay to the 91st day. So if you run across somebody on the phone, on your telesales or Zoom or in person, they have a long-term care, don't shy away from it. I have them go get it, because that generates a sale for me, because when I open it, guess what they forgot about? The elimination period. They're thanking me because I enlightened them to that gap, and then we in turn fixed it. But if you gave them a 90-day benefit, right underneath that you'll see with a lifetime maximum equal to twice the number of covered days. What that simply means is if you give them 90 days, they could potentially have up to 180 days. So an easy way for me to explain it to you, since I'm not in front of you, is if you picture you're holding your left hand out and your right hand out. Each bucket is going to have 90 days. So say they fell and broke a leg and they had to do physical therapy at a rehabilitation center. And the doctor said they were going to do it for 30 days, 4 weeks. At the end of those 4 weeks, they were released. In that bucket, now they're going to have 60 days left. They still have the 90 in the second bucket. Say they go 6 months from the day they were released from the physical therapy and they had a stroke and they had to do speech therapy and physical therapy. They can go directly into that second bucket, utilize all those 90 days, and if they had to, they can go back into the first bucket. Now, if they don't go the 180 days and performing 5 out of 6 activities of daily living, if they have another reoccurrence of a broken leg or a hip, they can go directly back into that first bucket and utilize the 60 days left. In order to get into the second bucket, they have to be released and able to do those 5 activities of daily living for 180 days. That's how they can get that second bucket. But that's how it works. There's a training video that explains it a little bit more in detail, but that's the most simplistic way that I've found to explain it to help agents out there, brokers, to understand how it works. It also has a waiting period. I recommend 0 day, but I'm not going to tell you how to conduct your business. I've always been a first day coverage guy because I want first day coverage for myself. And I've looked at the numbers and what the premium is versus 0 day versus giving them a 20 or 100 days. And it really doesn't make much sense to me to save them a few dollars on the month to expose them to a lot more out of pocket. So that's just how I go about that. But if you want to give them a waiting period, it does have the 20-day and 100-day waiting period. On a claim, if they want to utilize this policy, they have to be unable to perform 2 out of the 6 activities of daily living or cognitive. Simply, that's how it's done. The doctor will write up a plan of care, recommend what needs to be done, and then that's how they go about starting the claim process. It also has bed reservation up to 20 days, so that mimics long-term care also. So it's a great policy with a lot of great features on it. It also has a home care rider. I love home care. A lot of my clients rather be at home, so I love that they can do that. It goes a little bit differently than the nursing home benefit. The nursing home benefit is per day. The home care rider, as you can see, up to $1,200 weekly. So it's a weekly benefit. So if you give them $1,200 a week, their monthly benefit will be $4,800 a month. Then you can give them $750 a week. They'll have a $3,000 a month benefit. You can give them 6, which is $2,400 a month. So it's the same premise as the nursing home, but it's just in weekly. I generally give them $900 to $1,200, depending on the type of income that the person, the client that's sitting in front of me has. And then again, the covered weeks are 13, 26, 52. And just like with the nursing home benefit, if you gave them 13 weeks, they would have a maximum of 26 weeks. If you gave them 52 weeks, they would have a maximum of 104. So it's the same bucket premise as the nursing home and assisted living. On the claims for the home care, you can see it's a little bit different. In order for a claim to take place on this rider, they have to have 3 separate visits, at least 1 hour per visit. And it's because they can't perform, 2 out of the 6 activities of daily living or cognitive. But here's the good thing on the 3 separate visits. It doesn't have to be skilled. It can be the homemaker, like helping with bathing and dressing or housekeeping or shopping or cooking like that. So if they have 3 separate visits and 2 of them are for cooking and cleaning and 1 of them for physical therapy, boom, that's how the claim goes. So I love that it doesn't have to be just skilled. It can be homemaker and or skilled, which is a big deal for getting that claim started. I always want to throw this slide in because it's the general cost of care. For me, I like to make it real in the house or when I'm doing my Zooms of money that they could potentially have to spend if they have an accident, sickness, or surgery. And with this particular app, you can go into whatever city or whatever state, United States, and find out the exact cost for the nursing home or the home care agency right down the street from them. So you can dial in exactly what the cost is going to be if they had to utilize home care or if they had to utilize a nursing home, skilled intermediate care. So if you don't have that app, highly recommend you to get it. I use it weekly to show them the monies that they'll have to spend because they don't have the proper coverage for that particular service. And then I go about showing them what your cost is going to be, exactly what the cost is in their area. So again, you're talking about them leaning into the conversation when they see what the potential might be in their city at 97,747 if they had to stay in there for a year. That's a big deal. Or with the home care, $60,000 on if they had to utilize home care for a year. So it just makes it that much more real to them when you're showing them real time what the money is, what they're going to have to spend out of pocket. Again, it's getting that need across and that urgency. Again, like I said earlier, some people don't want to stay at home. With the recovery care plan, you can do a standalone home care plan, which I wish I would have had that availability when I was doing the long-term care all the time, because you had to give them so much nursing home to allow the home care rider to be presented to them. You don't have to do that on this particular policy. You can give them the bare minimum, $10 a day for the nursing home assisted living, 90-day, and then I will give my blessing on the waiting period. If you want to give them 100, it makes it a lot less because they're not really utilizing the nursing home, and it keeps that premium down. It's usually about $1 to $3 is what it costs when you do it that way. And then you can max them out on the home care, which I always do. I always max them out with $1,200 per week. Sometimes I give them 13 weeks, sometimes 26, sometimes 52. Really depends on who's sitting in front of me or on the other end of the phone. But that's how I utilize the home care, to give them just a true home care policy within that recovery care plan. Because a lot of times I'll ask them, hey, Ms. Johnson, if you did have an accident, sickness, or surgery, where would you prefer to recuperate? And then most of the time they'll say home care. The application is less restrictive than doing a med sup, but they're simply yes or no questions. As you can see, are you currently confined to a hospital, nursing facility, bedridden, require any assistance with activities of daily living? Within the past 3 years, 36 months, have you had congestive heart failure, any type of, cerebral palsy, multiple sclerosis? Within the past 2 years, have you had any amputations, prescribed oxygen? Here's what I'm going to stop on just for a second. Do you have diabetes? I've been coming across a lot more diabetic clients than I ever have before. And not all of them, but about 40% of them are on some type of insulin. If they're on insulin, as long as they're under 50 units, 49 units or less, they're a candidate to get the recovery care plan. That used to be a big knockout for me on the long-term care if they were using insulin. On this particular product, under 50 units, it's an issuable policy for them. So don't miss out on that. And then within 12 months, do you have any further evaluations, surgeries, any seizures in the past 12 months, alcohol, drug abuse? So the application for me doesn't take very long when I'm going through the questions in a household, usually about 5 minutes. But I want to be thorough with it because I want to make sure that I'm not skipping over everything. But it usually generally takes me like 5 minutes, 8 minutes to go through the health questions with them. And I make sure that I'm letting them know within the past 3 years, within the past 2 years, because sometimes they'll think about, 4 years ago, 5 years ago. That's not the case. It's within the parameters, 12 months, 3 years, or 24. If it's outside of that, then it's automatically a no. Us agents always want to know about premiums, and as you can see, Aetna did a fabulous job with putting the premiums together for any fixed income that we're going to come across with any client. If you gave them the bare minimum at $100 a day, $36,000 benefit, it's $42. You're looking at $400 and some dollars a year. No one's going to say that they don't want the policy because they can't afford that. Even if you want to the 200, again, it's under $1,200 a year. You go to the 300, which is $9,000 a month, still very, very reasonable for any fixed income. And even at $400 a day at $166 a month, again, it's very, very reasonable for any fixed income because you're looking at under $2,000 a year. And I go back to that slide that I talked about earlier. When you show them that it's going to be $80,000, $70,000 a year, and you tell them their premium for the year is $1,992, they're chomping at the bit to get the plan because they know that they're investing to protect their house, to protect their assets, to protect everything that they worked for their whole entire life from an unexpected sickness or accident or surgery. And again, I never have a client tell me that they do not want this policy because they can't afford it. Because as you can see, the premiums are very reasonable for the amount of benefit that you're going to get for the money that you're putting into it. If you just want to give them what I call the base plan or the recuperation or extended care plan, where you're just giving them 90 days, if you look at all the premiums from top to bottom, from $100 to $400, even at the $400 for 90 days, you're under $700 a year. Even my Medicare Advantage clients, none of them ever have a problem with premium. A lot of agents out there that sell Medicare Advantage assume that they only choose that particular product because there's a zero premium. I beg to differ. I sell a lot of Medicare Advantage clients weekly, and they never tell me that they don't want it because they don't want to spend any money. When you get the need across, they'll spend the money, as we all know. Now, the other policy we're going to be talking about is one of my other favorite policies that Aetna has, because of these reasons right here. These are all bad conditions that we don't like to see when we're in the field. Generally, typically, 99.99% of the time, these would be considered knockouts, where you wouldn't be able to give them any type of particular policy except for life insurance or something. But with the Home Care Plus, Aetna took that into consideration. So as you can see, most of these are like homemakers that they would need services, not generally skilled services. So the Home Care Plus is a little bit different than the Recovery Care Home Care because it's a skilled home care policy. So it's going to cover your physical therapy, occupational therapy, nutritional specialist, pathology. It's more of a skilled based policy. But what I have found is most of the people out there that have Parkinson's or dementia or Alzheimer's, when I explain to them that they can get a home care policy, they're really in love with that because they've been told no to long-term care. They've been told no to the short-term care. They've been told no. And then when they have an opportunity to get something, they're relieved that they have some type of coverage that's going to help protect them and protect their monies. It's the same premise as the recovery care as far as 50 to 89, no height, weight, no underwriting, no medical records, EAP, pays in addition to any other insurance, which I love that, no hospital stay required, or the renewal premiums don't increase, which helps our keeping our business on the books. So what are the benefits? It was $1,200 weekly. Agents in the field talked to Aetna and said, hey, can you bump it up a little bit? They listen to us because they value our input. They don't always implement what we tell them, but they do implement some of the things. And one of the things they implemented was raising the weekly benefit up to $1,500 a week, which is great. Again, as you can see, it goes weekly benefit and then the 13 up to 26, 39, 52 weeks. There is a 20-day waiting period, but I don't use the waiting period. Medically necessary. It has to be medically necessary. So if you sell someone that has dementia, they're not going to, once they get issued, they can't turn around and make a claim because they have dementia. They get the policy because they have dementia, but if they have a hip replacement, they have a stroke, they have a knee replacement, they have a need because something has happened to them, this policy will pay for those services, for someone to come into their home and do physical therapy, someone to come in and do occupational therapy. But here's what I tell them. If I gave them $1,200 a week benefit and they have a $4,800 monthly benefit, and after their 3 separate visits and at the end of the month and the end of their care, say their care only cost $3,000. Well, guess what? They have $1,800 left to utilize because that check is sent directly to them. So they can take that $1,800 and they can hire that same agency to come in and do homemaker services. So I always propose this policy to them in that way. Even though it's skilled, if you have someone coming in and your benefits, you know, 3,000 or 4,800, and it's only costing 2,000 or 2,800. That remainder of that money can be utilized for someone to come in and do the homemaker. So don't miss out on that. I also utilize this policy for a lot of my Medicare Advantage people because they have a hospital copay. As you can see, it has a hospital copay of now up to $400. So I utilize that rider on there. It also has some other good riders on there that I like. It has a lump sum cancer. It also has an emergency room and ambulance. So I always put some type of cancer rider on there, whether it's 2,500 or up to 10,000, because it pays at first diagnosis. If you give them 10,000, they get a check for 10,000, and the premium on that rider isn't very expensive at all. It's very, very inexpensive. So I always tag that on there for all my Medicare Advantage people that I'm selling that policy to. The application is a whole lot less than the recovery care, and the recovery care wasn't bad at all. But as you can see, are you currently confined to a hospital, nursing facility, require any assistance in activities of daily living? In the past 12 months, have you had a heart attack, kidney failure, stroke, any type of cancer, any surgeries or tests pending in the next, 12 months that haven't been satisfied? That is it. If you give them the cancer rider, then you have 2 more questions that they have to answer within the past 2 years. That's all the questions on the Home Care Plus, which I love. The premiums are just as good as the recovery care ones, as you can see. If you gave them what I call the recuperation part or extended care benefit at 13 weeks, again, it's right around $700 a year. If you gave them the 52 weeks at the $1,500, which is a tremendous benefit for that, it's still under $1,400 a year. So I know I sound like a broken record, but I really love that the actuaries in Aetna looked into the fixed income and the claims and all that, and they really knocked it out of the park with the premiums, because I honestly are telling you that I don't have rejections to get this policy because of premiums. I just don't. So you're probably wondering, no underwriting, no hospitals. How does Aetna do their underwriting? They use a Milliman program. And the Milliman program, what it does, it's going to look up what medicines they're taking. And then Aetna underwriters are going to compare what medicines they're taking, not the ones that we put on the application, but the ones that the doctors have prescribed for the past 3 or 5 years. And they're going to cross-reference them with the questions. So, for instance, if they're taking a methotrexate, which is typically a cancer drug, and you have down there they're not been treated for cancer, that's going to pop up a red flag, and underwriters are going to reach out to you and ask you what's going on with that. But that's how they do the underwriting. So this is what you're going to see when you do the e-app. I highly recommend, if you're not doing the e-app, it's really simplistic, and we'll go over that in a minute. But it will get your policy issued a lot faster than if you're doing a paper app. And the other thing that I like with the e-app, if underwriting has a question, they will send you a chat message or an email letting you know, hey, reach out to us. We have a question on one of the things on the application about question 4B. So they're not calling your client, they're calling and reaching out to you and getting your input. And then if you have to call the client to get their input for that to satisfy what underwriting is, they're coming to you instead of going to them, because you have the rapport with the client. It's better for you to reach out to the potential policyholder than for the underwriters to. So I love that with the e-app. So I highly recommend, if you're using the e-app, continue. If you haven't, jump on and use it. It gets you paid quicker, it gets their policy issued quicker and sent out to them. And I want to highlight this right here. Last year, I had 3 declines. And the reason I had the 3 declines is because they failed to tell me about a medicine. Because Aetna, on aetnaseniorproducts.com, as you can see right here, when you pull that up and you sign in, you're going to have this screen come up. And if you see where it says products, if you click on products, it's going to populate drug list. So when you're in a house or you're on a Zoom or a telesales call and you're going through their medicines, you can pull up that products and it'll pull up the drug list. You can put in their medicines for the Recovery Care Plan or the Home Care Plus, and it'll let you know if it's a knockout drug. That's why I don't have any declines, because I utilize that drug list. I push their drugs in, and it'll let me know if it's an acceptable drug or not. So for instance, if I'm doing a Recovery Care Plan and they're taking a drug that's not acceptable, guess what? I'm pivoting to the Home Care Plus, right? Real time when I'm in front of them or on the phone, instead of having to call them back or go see them again. That's why I stress, go in, do that e-app, because you can go in there and you can look up their medicines. There's no question whether that's going to be issued or not, unless, like it happened to me 3 times last year, they just fail to give you a medicine that they're no longer taking, or they're supposed to be taking it and they're not taking it. Which some of my clients will tell me, yeah, my doctor prescribed me this, but I just don't take it anymore. But they keep getting it prescribed to them. So this is what the e-app looks down here, and you can even do a training on it on the portal, but it'll populate these questions, and you'll start out from the very first one and go all the way through. As you can see on the right side, if it's highlighted in pink, that means that you didn't fill something in correctly or you just missed it. It won't let you go to the next screen until you fill out the ones that are highlighted in pink. So there's no way to have any errors or any confusion, because it's pretty simplistically done and anybody can do it. So when you go to that drug list and the script check, it's going to pull up medicines, and it's going to have an X on it, like you see here on the right hand corner, which means that it's a knockout drug. But here's what I want to highlight. There's a lot of dual drugs out there. So make sure when you're looking at that drug like Actigol that's for cirrhosis, if they're taking Actigol for cirrhosis, then that drug's a knockout for my example, this hospital indemnity policy. If they're taking that Actigol for any other illness besides cirrhosis, it's acceptable. So like my drug of nemesis, my one drug that used to always knock me out was methotrexate, cancer drug. Well, now 2024, methotrexate is being utilized for arthritis. So if they're on methotrexate for arthritis, that's a dual drug. It's acceptable. So that's why I've kind of highlighted and kind of focused in on the drug list, is because if you do your due diligence and put the drugs into that drug list, there's no reason why that policy is going to be declined, because a lot of the drugs out there now are dual drugs. So make sure that you're looking to make sure that that's not a dual drug, and that policy will be issued. The other thing that I want to highlight is the Aetna Quotes on the Go app. If you're not utilizing that or know what it is, if you have an Android or an iPhone, you can simply go in and go to your app store and put Quotes on the Go. Don't put Aetna in there, but put Quotes on the Go. And this is what you're going to see. You can punch in any zip code across the United States, and it's going to pull up every product available in that state. So you don't have to have a hard copy sheet that lets you know what all the products are available. If you have the Quotes on the Go app, you punch in the zip code, punch in their age, and then you can go directly into whatever policy, figure up a premium, put it in the cart, go out and figure another policy out. But if you don't have the Quotes on the Go, I highly suggest you get it, because it's a great tool. I utilize it every single day. Another thing that Aetna provides for you is if there is a need for a claim and a client wants to know how to do the claim, these claim checklists, check boxes, whatever you want to call them, are in there for your resource, for agent resources, and you know exactly what to tell the client that they need to get, or you can help them get, in order to get that claim processed effectively, efficiently, and really quick. So there's no reason for a claim not to be filed and issued promptly if they have the correct stuff. So there's no reason why you can't help them, or there should be a lag on getting the claim processed, because they make it really simplistic and easy for you and let you know exactly what your client needs to get that claim going. And I'll end with this. Like I said earlier, Aetna's been around for a very long time. 1853, they paid the first Medicare benefit. They've been doing it right for 170 years. I believe they'll continue to do it right. They're for the clients, the insured, and they also value the agents. And with that, any questions, I'll address them.
Awesome. So a lot of the questions you actually answered as you were going through. That's why I was waiting to ask some of them. We do have a few more specific ones, but we'll get those on the follow-up calls after the webinar, just because they're not going to apply to everybody. So, but perfect. Yeah, I just want to say thank you again for running through that. There was some great info, especially some key pieces where you were covering the cognitive kind of knockout questions that you see on most, policies, products out there, not being an issue when it comes to, the home care and different things like that. So that's going to be really useful to hopefully get some more sales for our agents out there. There are a lot of options out there, so don't really limit yourself. Whether you're doing Med Subs, Med Advantage, and this is a quick, easy way to kind of get some more sales. Make sure you have some other products with your customers that are going to kind of be sticky products that'll keep them around a bit longer with you as an agent. Like Ronnie was saying, 5 to 10 minutes to get through the app. Very, very lenient as far as the underwriting, so it's a great thing. And it's a great product. It's a great company. I mean, everyone's going to know the name. It's going to sell itself. As you guys saw, it's very inexpensive, so you should have very little to no rejections based off of premiums. No matter what their financial situation is, there's different ways to build it. So I just want to say thank you for everybody for being here. Thank you again for Ronnie for running through everything. And those specific questions, we will reach out to you guys and follow up. If you do have any questions that pop up later, feel free to give us a call in the office at 800-672-7202. But thank you again, and I hope everybody has a great day.
Thank you.